That should be good.
Sure, whatever works for you. I don't mind anything.
Okay, sounds good. All right, so we'll get started in just a bit.
I think Mona is also here as well, but I'm not
Okay.
sure if she's joined yet.
Okay. Sounds good. Good morning, everybody. We're gonna get started in about a minute. Just waiting for a few more people. All right. So just like last time, we're going to use YouTube for chat. I realized that for Teams, you would have to be added to the group and to the organization. And so it would take me quite a bit of time to do that. So I haven't been able to get to it. If I can in the future, I'll let you guys know, but it seems to be working okay. We have about 4 more sessions, not including today. I wanted to bring up, let me see if I can pull up my screen. This one. Okay, can you guys see that okay? Yeah, it looks like you can. Okay, cool. So this was kind of the schedule that I sent out. Today's what, the 10th? So we're at session 6 right now. So we have 4 more. We have 7, 8, 9, and 10. So we'll keep to this schedule. So session 7, I believe Shivani's gonna be helping me with that one. We're gonna put a case together. Shivani is a medical student over at Western University, so she's been helping out with a few of these cases, and I believe one of her colleagues, Mona, was also helping out too. 8, 9, and 10, I had planned 2 cases and a kind of interactive type lecture. So the next 2 cases are going to be, they're going to be focused on a similar problem that a patient presents with, but they have different outcomes. And the reason why I want to do that is to show you like the importance of knowing what the general process is of underlying disease processes. And so that goes into different like theories of how you learn medicine and learn in general, and something called illness scripts. So we'll talk about that as we get into that into those lectures. And then the last session, I'm not 100% sure what we're gonna do for that one, but I was planning on a lecture about vaccines, and so I'm not 100% sure yet, but I'm gonna try to make it interesting and not just vaccines are great, which they are, but I'll give you guys a heads up a bit closer to the date, because there may be some more interactive elements in that talk. Any questions about anything at all? Okay, so the other thing that I was gonna bring up, the site should be good now, so you should be able to enroll in all these courses here. So the VMR session 4 from a few weeks ago is up, so go ahead and get that done whenever you get the chance. I'm gonna put 5 and 6 hopefully today, and then like I said before, you're gonna have till the end of the program to finish everything. What you're going to be responsible for is the abdominal pain, the chest pain course. I may have an abdominal pain course up there in the near future. So not exactly sure whether or not you will be responsible for that. Most likely not, just because of the timing. And then each of these session quizzes and courses I'd want you to do as well. If we need to give you more time to make sure that we have everything like squared away and you're able to actually complete the course, we'll make sure that happens. If you want to invite anybody else to join and complete the course with us, it's not too late. I basically have decided that if you want to join, you can. As long as you finish all of the sessions, you'll get credit for it. Questions about that? Cool. So we'll jump into the case today. We're gonna do, just because I didn't have enough time to put together a quiz, we're gonna do another one of these cases, but I'm gonna give you, I looked through the majority of them, we're gonna give you a choice on which one we'll do. So there is, and just put it in the YouTube chat, whichever one you want to do. So the ones that I saw that were a bit more interesting and more relevant was the vaginal bleeding in pregnancy in a 32-year-old woman, and then the other one, where is it at? Was the exertional dyspnea, exertional shortness of breath in a 76-year-old male. So which one of those would you prefer to do? And just put it in the chat on YouTube. The other one that was really good, but we did it before last year, was the cough in the 2-year-old boy. Maybe if you guys are interested in that one, we can do it at a later time. I don't see any. Okay. Does anybody want to just say which one they want to do? Because I don't see any updates in on YouTube. The second one, so the shortness of breath, so the non-pregnancy one. So the shortness of breath. Okay, so the first option was vaginal bleeding in a 32-year-old pregnant woman. And then the second one was dyspnea on exertion, so the shortness of breath in a 76-year-old male. Good with either. Okay. Okay, let's. Okay, so a few of you guys are saying pregnancy. Okay, if we have enough time, we can quickly go through the shortness of breath one too. Okay. So I'm not a OB doctor, so there may be things in here that I don't quite know. So if there is, then we'll learn together. All right, so we have a 32-year-old female comes into the ER with painless vaginal bleeding that began earlier in the day. She is at 36 weeks gestation in her third pregnancy. She's had one previous full-term pregnancy and one spontaneous first trimester abortion. She had a small amount of brown discharge on the toilet paper while wiping this morning. Later in the day, she noticed dark red blood on her underwear and decided to come into the ER. She denies fluid discharge, abdominal pain, or cramping, and she is feeling usual fetal movement, no abdominal trauma. She received all routine prenatal care and reports everything has been normal until now. So,
Dr. Naqvi, I don't think we can see the slides, but I'm not sure.
Oh, thank you for letting me know. Hold on. Okay. Can you see that?
Yeah.
Awesome. Okay, so let me just pull this up real quick. So let's summarize this. So we got a 32-year-old. She's on her third pregnancy. She has one successful pregnancy. The other was an abortion. She's been having brown discharge and later bleeding. and it doesn't look like is it painful or not painful? She denies abdominal pain and cramping, and the baby is moving okay. There's no trauma. Okay. So let's get into the review of systems. And then we're gonna go with Emma. And just think about what in here is going to be important. So she has appropriate weight gain in pregnancy. She feels fatigued for the last few weeks, but's been able to do her normal duties at work. No falls or injuries. No rashes or bruising or bleeding. No shortness of breath. No bleeding from nose and gums. No palpitations or chest pain. No nausea, vomiting, abdominal pain. No urinary symptoms, no musculoskeletal symptoms. Neuro's okay. So she is G3P1011. So what that means is third pregnancy, and it's kind of like what we talked about before. She's had one live birth. She's had a total abortion and an abortion, and then this is a current pregnancy right now too. So it's just basically shorthand to say what her pregnancy status is. No other episodes of vaginal bleeding during this pregnancy. She had a routine ultrasound in 20 weeks and it was told it was normal. She's unsure of her RH status, and then psychiatric non-contributory. So Emma, anything in there that is important to know?
I did have a question. Can you break down the G3, like the code?
Yeah, so let's gestational so here is, let me see. So basically there's a really good picture that we usually pull up. So the G's are it means gravidas. That's the number of pregnancies. The para is the number of births. So for her, we can go back. So she has 3 pregnancies, 1 birth, but then you break it up into what they call it TPALs. So T is the full-term pregnancy, so she had 1. P is a preterm delivery. So this is a baby that was delivered after 20 weeks. She has, but before 36 weeks. And so she had 1 full term, no preterm. And then A is the number of abortions and miscarriages before 20 weeks, and L is living children. So for her, she has no, I thought she said she had an abortion. Oh no, the third one is abortion, and then the L is the 1 living child. So the G's and P's, if you're pregnant, usually will have, if I remember right, most of the time they're not the same, right? So if we're just doing G3, she would technically be G3P2, but when you break it up, she's GP1011. I feel like I'm confusing you guys more. Does that make sense?
Yeah, that made sense to me.
Okay.
Yes. So to answer your question, the things that stand out is her spontaneous abortion, and the fact that she's having dark blood. I think that typically means the blood is old. So those 2 things are what stick out.
Yeah. So she did have the brownish discharge, which is a lot of times that older type blood. Dark red blood in general, it can either mean that it is older and it's clotting, or it just means that it's dark red blood. It doesn't really tell us anything about how old the blood is. If there's a lot of clots, that tells us that it may be older, or it's a higher volume of bleeding. So what about RH status? What does that mean?
So that's like her blood type, and the type of antibodies she has on her red blood cells. So Rh positive would be like, you hear about there's B positive or O positive. That means you have that Rh factor.
Yeah.
I'm not sure if I'm explaining it coherently if
no.
people aren't familiar. But if the mom is Rh negative, and then the baby is Rh positive, then the mom's antibodies attack the baby's cells. I think that's if I'm
Yes.
remembering correctly.
Yeah, perfect. So it's part of our blood typing. So we have ABO blood types, and so the ABO is the major component of the three different blood types that we have. The Rh factor is one of the molecules within the blood cell itself. So if you're Rh positive, you have presence of the Rh protein, and so if somebody is Rh negative, meaning they don't have that Rh protein on their blood cells, if baby is Rh positive and their blood gets introduced into mom's blood system, her mom will start producing antibodies against the Rh protein because it sees it as a foreign factor, just like our body will try to reject things that are foreign. If you get a bacteria in your bloodstream, or if you have what's another like within transplants. So if you get the reason why we have to suppress the immune system so much in transplant patients is because yes, we try to make them as compatible as possible, but there's a ton of different factors within the tissues, and so if the body starts seeing those different factors and starts mounting a response, your body will basically reject that and destroy that the organ. And so for in this case, it's the baby. The baby's the organ. So if a baby is Rh positive, mom is Rh negative, and mom is exposed to baby's blood cells, she'll start producing a reaction to it and start attacking the baby. And so if a mom is Rh negative, we typically will give a medication called RhoGAM to prevent that from happening, prevent the creation of those antibodies against the Rh factor. Does that make sense? Yeah. Okay.
Yes. Sorry, I had a question. What causes the mother to be negative and the baby to be positive?
That's a good question. So if mom is negative, right, because this is all genetics, then what do you think baby gets the Rh positive from?
Is it just a mutation?
Mm-hmm.
Or the father?
The father, exactly. It's the dad, right? So sometimes you can get you can test father's blood as well. And to be honest, it's been a while since I've been on L&D. I don't know how often they'll test. But for the most part, from what I've seen, we give the RhoGAM. Elizabeth is asking, does this happen frequently? In terms of ABO incompatibility, or not ABO, the RH mom producing Rh factors and attacking the baby, no, because we typically are able to give RhoGAM, which RhoGAM, if I'm remembering correctly, it basically prevents, actually, if I remember right, it prevents the mom from producing those antibodies, but I'm not exactly sure how that happens. So that's too small. We'll take a look at that later. I'll keep that open. Unless somebody knows exactly how that happens and they want to share. But in terms of frequency, if baby is being attacked by mom's antibodies, a lot of times baby's not going to survive that. And so you'll have those spontaneous abortions. There was one other thing that I was going to bring up. Oh, so if this is a first-time pregnancy, and mom let's say we didn't know mom's blood type. She presents late in pregnancy, and later on, you find out that mom is Rh negative. Is the baby at danger? Is that baby at danger? Fatima, what do you think?
Wait, sorry, could you repeat the question?
So if this is the first pregnancy for mom, forget about our case right now, but if this is first pregnancy for mom and she comes in late, she doesn't have good prenatal care, and so she comes in late in her pregnancy and we find out that she's Rh negative. All this time has passed, is baby at danger?
Yeah, if it's the first pregnancy, and then I think, and the baby's Rh positive, she would be much more likely to produce those antibodies, I think.
Yes, but only when there is a mixing of that blood,
If
when
there's a
they're
mixing of
exposed to the blood. So in first pregnancy, it's not that baby typically is not at danger. It's usually within at birth where you have that exposure. And so subsequent babies may have because mom will get exposed, she may produce the antibodies, and so subsequent pregnancies may have those babies may be in danger because mom now has the antibodies. Because unless mom is exposed to the Rh positive protein, she will not produce those antibodies, and so usually it's not until the end of the pregnancy when baby delivers. Does that make sense?
So the mixing of the blood is more likely when the baby delivers, right?
When baby delivers, if there's trauma, and you get exposure of baby's blood into mom's system, for the most part, there is always some amount of baby's blood in mom's bloodstream. And there's a test, I'm forgetting what it's called, that checks to see how much of baby's blood is in mom's bloodstream. But usually that's such a low amount that it doesn't typically, it wouldn't necessarily cause production of the Rh factor or the Rh reaction where she starts producing antibodies. I'll try to remember the name of the test as well. Does that make sense?
Yeah, so like that baby, so since it's already going to be delivered, and then the antibodies get produced at that time, but then when more babies come in, then it's like, okay, this is inside now, right?
Yeah, so by the time that the mom becomes pregnant again, she already has those antibodies against the Rh factor. And so because she has those antibodies already, as soon as mom is exposed to Rh positive blood, her antibodies will ramp up and they will start attacking the baby if the baby is Rh positive. If the baby is Rh negative, then it's not a problem. The baby will be fine.
Makes sense. Okay.
So the rest of this, I don't quite see anything really contributory. Her 20-week ultrasound looked okay. All right, we can move forward. So past medical history, she has asthma, no recent exacerbations, no history of bleeding disorder. And we'll go with Crystal for this next one. So menarche, just whatever you feel is important. So menarche at the age of 12, one first trimester miscarriage 6 years prior, one uncomplicated full-term vaginal delivery of a healthy 7.5-pound female infant 3 years prior. She received all of her prenatal care at another facility, so there's no records. She's taking prenatal vitamins and albuterol as needed, no allergies, no family history. She smokes 2 cigarettes a day, down from a half a pack a day at the beginning of her pregnancy, no alcohol or drug use. She lives at home with her fiance and her daughter. She's employed as security guard at a local college. So anything there that's important, Crystal?
I'm a little concerned about how she is smoking. I'm not sure if she's ceased smoking, like if maybe she just didn't know at first and as soon as she did, she stopped, or if she's going to continue smoking during the pregnancy because that does cause complications.
Yeah, it looks like she's still smoking.
Okay.
She's smoking 2 cigarettes a day. Before she was smoking half a pack's about 10 cigarettes a day.
Which is a lot less, but still concerning. So I was wondering if we could test the father, because I'm not sure if it's a different father this time, to see if he is Rh positive, to see if this could be an issue again. I'm not sure how that would work, though. I'm not sure if after the first pregnancy, if just like anytime the mom has a child, it's an issue, or if it's only for Rh positive blood type children.
So we actually don't know what the blood type is for this patient. So we don't know the blood type. We don't know baby's blood type. We don't know dad's blood type. It was just kind of a exercise that I wanted to go through and think about the physiology and why that Rh positive, the Rh factor is so important. And it's one of the first tests we do when a person comes in when they're pregnant. So actually, did they say she was Rh positive or negative?
I don't think so.
I think they said it was unknown.
Unknown. Okay. Perfect.
Okay.
Yeah, unsure of her Rh status. Perfect. Thank you. Okay, so we talked about the smoking. Anything else here is important?
The first miscarriage 6 years ago.
Yeah, so she had a miscarriage 6 years ago. We don't really know why. It was in the first trimester. So a lot of times that's where the majority of miscarriages happen. And I forget the statistics, but there's a good amount of spontaneous abortions that happen. And, if it's before, if it's within the first trimester, there's really not much we can do. Okay. There's one other thing here that stands out to me that's important. Any thoughts, Crystal or anybody else?
What is menarche? Is that like the first period?
Oh yeah. So that's the first period. So her first period was at 12 years old.
Okay. I think asthma maybe would be concerning.
Yeah, I mean, she's not really having any shortness of breath, so probably not as important for this one. What was standing out to me was that she's employed as a security guard. And the reason why that is, do you know why that would be important?
High stress, but also at risk of injury or violence.
Yeah, exactly. So high stress, but more importantly, the injury and violence part. Because if she was, let's say she was hit, and I think they said if I remember right, I should probably write notes for this, for these, but I think that she said that there was no trauma, if I'm remembering right. But if she works as a security guard, it's pretty physical. If she was assaulted or, if anything happened at work and caused trauma to the belly, that can potentially cause the bleeding. Usually we see like for abdominal trauma, we would see something like in like a car accident. So a lot of times if you're in a car accident and the seatbelt pushes on the belly, it can cause an abruption of the placenta where the placenta will kind of separate from the uterine wall, and it can cause bleeding like that. Typically, though, it's not painless, and I think they said that she wasn't having any pain. It can cause a lot of cramping and pain, so it may be a little less likely at this point, but it's possible. Questions about this so far? Okay, so we'll move on. So she appears well. She's in no distress. Vitals look, vitals, her temp is 37, pulse 88, blood pressure 118/64, respirations 20. And Elise, we're gonna ask you to kind of look at the physical exam. So no petechiae, which are little pinpoint red dots usually is a sign for low platelet levels. And we can pull up a picture if you guys would like. No ecchymosis, so no bruising, no other lesions. Eyes look normal, so no scleral icterus or signs of bleeding. Lungs are clear. She has mild tachycardia, regular rhythm, no murmurs, rubs, or gallops. She has a gravid abdomen, which means that it looks pregnant. Fundal height is how high the uterus rises in the abdomen, and it's normal for her dates. The tone of the uterus is normal, so it doesn't feel very firm and hard, feel like it's contracting down, and it's not tender. So she has a scant amount of dried brown blood in the introitus, so within the vaginal opening. On speculum exam, there's a few milliliters of dark red blood that are present in the vaginal vault. Cervix appears approximately 1 centimeter dilated, no active bleeding. Not bimanual exam, which is just an exam of the cervix and the uterus. That was not done. So what are your thoughts? Anything in here stand out? Okay, so we'll go with Jeanette. Anything that stood out to you?
From the physical examination, one of the things that did stand out was the so there was the dry blood in I'm not sure what that word is, but there's the dry blood. And center being dilated, is that concerning? I feel like that's concerning slightly.
It is. It is because that tells us that the body's pretty much. So the cervix opening up is basically a sign of we're getting ready to have the baby. It doesn't mean that she is in labor right now. It just means that things are kind of opening up and prepping to deliver. I'm gonna check something real quick. She's at 36 weeks, so she's a little early for that, but it's not, extreme where we're gonna have to. Where if she delivers now, it is a bit early, but for the most part, babies are okay. We may need to give additional medications, but baby should be okay. Other thoughts?
Her vitals look like in the normal ranges. Her blood pressure is like a little toward the higher side, but it still looks in the normal range. Her mild tachycardia, a little bit. That could potentially be related to the dilation. Who knows?
Yeah, so maybe if she's uncomfortable, she might have a little bit of tachycardia. It's weird, they say mild tachycardia, but her pulse is 88. Her blood pressure looks okay, so I'm not super concerned about that. And then her temperature and her breathing looks okay too. Anything else?
What is a bimanual examination?
So all that is when we do a speculum exam, right? So that is with the speculum. It kind of looks like something that opens up, kind of like an alligator thing. I'm not explaining it very well, but basically the speculum is there to look inside the vaginal canal and look at the cervix. So we would typically use a speculum to kind of open things up and kind of see within the canal. Then afterwards, we will sometimes then go use our fingers to examine the actual cervix, see how dilated the patient is, and then see if a patient's not pregnant. We will also kind of move the cervix and the uterus and see if there's any tenderness there. If we're looking for something like a pelvic inflammatory disease because of like gonorrhea or chlamydia, you doing the bimanual exam and moving the cervix and the uterus is extremely painful. And so it's really important to see. The other thing that we would do on a bimanual is we'll use the other hand. So if we're putting one hand in the vaginal canal, the other hand is on top of the belly to see if we feel anything on the uterus or on the ovaries. Typically, if you're doing a bimanual exam, you won't feel the ovaries because they're so small. But if you ever do feel the ovaries, that's something that is concerning for either a very large cyst, a mass on the ovary, and things like that. Does that make sense?
Yes, it does.
Okay.
And I think the last one was just a few millimeters of dark red blood in the vaginal vault. That's like the last concerning thing that I can see from this entire exam.
Yeah, and that just tells us that she is bleeding. So, yeah, I think somebody put the normal uterine tone is important to rule out abruption. And yeah, so typically if you have an abruption, like I said, actually let's just pull it up. Until abruption. So, all right, so this is the uterus right here, right? Baby's inside, the placenta's here. The placenta will start to separate from the uterine wall, and you'll start bleeding into this area. That blood is pretty irritating, and so the uterus will start to cramp up and contract. And so if that happens and we see that baby is not doing well, meaning we get like the rhythm strip, we do the fetal monitors on them, and it looks like they're not doing very well, that's a reason why we would need to do like an emergency section. So this is actually a pretty good ultrasound that shows the blood that's there in between the uterine wall and the placenta. Okay, and then there's different areas of, I think there's different areas where the abruption can happen. So if it's something like this, or actually this first picture, if it's something like this, and this is kind of closed off, you may not have any bleeding happening. But if you then kind of look at this picture, let me see if I can make this bigger. You can see that if the blood starts to leak out behind the baby, that's when you have the vaginal bleeding. Otherwise, this may not, this abruption here, you may not have any bleeding at all, just the abdominal pain. Questions about that? Okay. So let's move on. So what's our differential diagnosis? So abdominal trauma, she denied it, but you never know, especially if she's having the bleeding. So we'd want to make sure that we rule out trauma. Cervical polyps can cause some bleeding, but I would have expected them to see that on exam. So a little less likely. We didn't do a cervical exam. I didn't say that the cervix looked inflamed or anything like that. So cervicitis, I'm not 100% sure if we would include that in the differential. If we would, it would probably be a little lower. Endometrial cancer, I mean, I would assume they would have seen that throughout the pregnancy if there was any type of endometrial cancer. So I think less likely. Hemorrhoids wouldn't cause bleeding within the uterus and in the vaginal canal, so it's most likely not hemorrhoids. A miscarriage. Do you guys remember? I think they said that the baby was moving okay, right?
I don't remember them saying anything about the baby.
I think
usual movement.
What was that?
It said usual fetal movement.
Oh, okay. Where did it say that? Was that in HPI? Oh yeah, she's feeling usual fetal movement. Okay. So yeah, so then, shoot, I don't know what we put so far. So I said yes, abdominal trauma, no to cervical polyp, no cervicitis, no endometrial carcinoma, no hemorrhoids. So miscarriage is going to be less likely if the baby's moving normally. Onset of labor, possibly yes, because of the dilation of the cervix. So I would add that. Placenta previa. Does anybody know what that is? It doesn't look like it. But if we
Is
take
that,
uh-huh.
sorry, is that when the placenta detaches or it's like not securely on?
No, so that would be the abruption. Abruption means like separation. So placental abruption is if this is the uterine wall, and this is the placenta, and it starts to kind of come off. That's when you have the bleeding in between the layers. So I think placental abruption is definitely a possibility. Placenta previa, if you kind of take away, I mean, you kind of break apart the words. Previa, the way that I think of it, it's like a preview. So it's when the placenta lies low in the uterus, and it kind of is over the opening of the cervix. So yeah. So it's kind of like this, where the placenta is over here, sitting right on that opening of the cervix, and so this can cause bleeding. So if this and this may actually be placenta previa. If this starts to bleed for whatever reason, it'll kind of just bleed out here, right? You don't have that accumulation between the baby and the uterine wall. It'll just kind of bleed out intermittently. And so there's different levels of placenta previa. Let me see if I can blow this up. So we have just a low-lying placenta where it's close to so the placenta's right here. It's close to the cervical opening. We have a marginal placenta where it's kind of just the lip right there is over the cervical opening. Partial previa is it's basically not completely over it, but for the most part it is. And then complete previa is all the way, the placenta is just completely over that. And so patients with placenta previa cannot have a vaginal delivery, because if you're trying to push baby through this through the cervical opening here, you're pushing through the placenta, you're going to compromise the baby's blood supply, and babies can die. So you have to do a C-section. Questions about that? Cool. So I would say yes, the placenta previa, probably a little bit more likely, because typically bleeding in placenta previa is not necessarily painful. A UTI wouldn't typically cause bleeding within the vaginal canal, so a little less likely. And then vasoprevia. If placenta previa is the placenta overlying the opening of the cervix, what do you guys think vasoprevia is? What would vasa potentially mean?
Blood vessels?
Vessels, yeah, perfect. So let's see. Vasoprevia is this, where placenta is totally fine, but you have the umbilical cord that has all the blood vessels for the baby that connects to the placenta. The umbilical cord is what is over the cervical opening, or right at the cervical opening. And so let me see, there like, this is a good picture. So this also compromises the ability to do a vaginal delivery, because you're again compromising that blood supply going to the baby. Questions about that? Okay, so would vasoprevia cause bleeding like that? To be honest, I'm not 100% sure. I don't think so, because if you're having a disruption of the umbilical cord, and you're having bleeding from the umbilical cord, that significantly compromises baby. And so babies have a very low blood volume total as compared to adults, so they're not able to lose as much blood as we are and be okay. So if there was bleeding that was from the umbilical cord, I would assume baby would not be doing very well. I don't think that baby would be moving as well as before. So I would probably leave that one out. And I got it wrong. Okay, so abdominal trauma, the degree of trauma must be significant and would have been noticed or reported by the patient. That's true. Cervical polyps can cause bleeding, and though none were seen on exam, they can be internal. That's also true. The cervix is hypervascular in pregnancy and more prone to bleeding from minor trauma such as intercourse or an internal vaginal exam, or when cervicitis is present from a vaginal infection. I would assume, though, they would have said something about, inflammation of the cervix. So I'm not sure about that one. And then vasa previa, labor can cause bleeding when vasa previa is present. Oh, I guess, if we're saying that she's in labor. This is less likely given the patient has not been having symptoms of labor, but it is still possible. Okay. And then the two that I would say probably more likely at this point, placenta previa must be considered in the differential diagnosis of a third trimester bleeding that cannot be ruled out in this patient based on physical exam. Typically, though, placenta previa, we would have known about it because of the normal ultrasound at 20 weeks. And if it was a marginal previa or something that would have or something that would have been significant enough to cause this bleeding, we probably would have seen it, or there would have been some mention of it on the ultrasound. So I'm thinking that's a little less likely now. And then placental abruption must be considered as a differential diagnosis within third trimester bleeding. Okay. So what testing do we want to do? Anybody want to try this? All right, Joey. We're gonna do a few of these. So, blood type and screen. Would you want that?
Yeah, because she doesn't know her RH, so we might as well just get it.
Yes. Complete blood counts. Is that important?
I guess to see if she's losing a lot of blood.
Yeah, so if she has been bleeding, we'd want to make sure that she's not losing a ton of blood. She's not becoming anemic, especially if we're thinking of something like an abruption where she may need surgery. We'd want to make sure that. So cross-match 2 units of packed red blood cells.
Only if she's really low on blood, and I don't think she was passing out or anything.
Yeah, it didn't say that she had any symptoms of a significant anemia. A digital vaginal exam. Would you want to do that?
We know that the blood's in there, so maybe.
Yeah. So the only thing that I would be hesitant about is if this is something like a placenta previa and we do a vaginal exam, sometimes that can disrupt the placenta and cause even more bleeding. So yes, I think Jumbo Shrimp put digital exam is contraindicated, so we wouldn't want to do that. So until we know that this is not a previa. External fetal monitoring with tachometry. What about that one?
We might want it just because even though she said it was normal, we don't exactly know what's going on in there.
Yeah, exactly. Fetal fibronectin. Do you know what that is?
I have no idea.
I forget that. I think that is looking at amniotic fluid. Shivani and Ramona, do you know what that is? Okay, yeah. So it's a protein that's believed to keep the amniotic sac glued to the lining of the uterus. So yeah, fetal fibronectin can be released into secretions near your cervix. So a lot of times we'll get I think it's been a while since I've been on L&D, but we'll do the fetal fibronectin to see if any of the fluid in the vaginal canal is amniotic fluid, which would tell us if there was a rupture of membranes. If I'm remembering right. And if I'm wrong, I'm going to look this up and I'm going to let you guys know. So I would probably want to get it. What about the fetal growth scan, Joey?
I don't think so.
I think she already got the growth scan. Typically, we do that at about 20-ish weeks. And so I'm not sure. I don't think that we would need that. What about the ultrasound? Just
Yeah.
general. Yeah.
I would say yes.
Okay. And then the Kleinhauer-Betke test. That is the one. That's the RH test that we talked about. That is like if baby's blood is present in mom's bloodstream.
Yes.
Okay. Fibrinogen levels. Do you know what that is?
No.
So fibrinogen is it's something that we can test for that is basically used up when you are when you're having clotting. So if you have blood cells that are aggregating and clotting, fibrinogen will be used to form that clot. So in the reason why this may be important is in somebody with preeclampsia, you can have something called HELP syndrome, where you have where basically you'll have your platelets being used up because you're having a bunch of clotting going on, but it's not necessarily clotting like we've been talking about before, which causes like a pulmonary embolism or a DVT. These are like clots happening everywhere, and so having a I think it's a low fibrinogen level can let us know that she may be at risk of something like that. So it doesn't seem like that's going on, and I probably gave a really bad explanation of this. But for me personally, I probably I wouldn't necessarily need the fibrinogen levels right now. Same thing with the serum PT and PTT, which both of those are measurements of the patient's ability to clot. And so if these are abnormal, it may show that the patient has a more difficult time clotting off, and so she's more prone to bleeding. So actually, that might be important. Okay, so yeah, serum fibrinogen is necessary to assess for consumption coagulopathy. So basically, if you're using up all your all your platelets and forming clots everywhere, it's going to be important. Yeah, so the Kleinhauer-Betke test is used to approximate the amount of fetal blood in maternal circulation. So you want that. We want the ultrasound. The growth scan may be appropriate if decision is made to proceed to delivery. However, this study would not guide management of third trimester bleeding. Fetal fibronectin used to rule out preterm labor, but is likely to be less accurate in the presence of blood. Okay, I didn't know that. So we want to fetal monitor. Digital vaginal exam should be avoided in the setting of third trimester bleeding without a known placental location to avoid further disruption of a potentially bleeding placenta previa. So yes. So we don't need, they're saying we don't need packed red blood cells because there's no evidence of active bleeding or hypovolemia. We want the CBC and we want blood and type screening. Cool. So here are our results. So Mona, if you are on, I'm going to ask you to look at these. So external fetal monitoring and tochometry, she has a few irregular contractions and a reactive fetal heart rate tracing at 150 beats per minute. Ultrasound shows a cephalic presentation of the fetus and a fundal placenta with its margins clear the region of the cervical os. Amniotic fluid index is 15.7, which is normal. And we'll go through what all of this means. Hemoglobin is 10.9. That's a little low, but in pregnancy that can be normal. Platelets are at 238, so that is normal. Or her type and screen is A positive. She's negative for the Kleinhauer-Betke test. Fibrinogen is 408, and it's within the normal, and PT and PTT is normal. So Mona, why don't you help me interpret this?
Hi.
So let's get the first part. So external fetal monitoring and tochometry. She has few irregular contractions and reactive fetal heart rate at 150. Do you know what that means?
So it's high, the 150 beats per minute.
So it's actually for a baby, it's normal. So 150 is okay. And so she's having some contractions. So it looks like her uterus is contracting. This may be, the very, very beginnings of labor, but it doesn't look like she's in labor right now. And when we say reactive fetal heart rate, we can give a whole hour presentation on fetal heart tracings, but basically that means that the heart rate looks normal. So in babies, there's normal variability of heart rate, so it'll go up and down, and that's completely normal. And so when we say it's reactive, it means that it has that normal variability. So that's good. So baby looks good at this point. What is cephalic presenting fetus? What does that mean?
Actually, not sure.
It's okay. So think of anatomy. What does cephalad mean, or cephalic?
Like towards the head.
Towards the head, exactly. So the head is the presenting part of the fetus, so that just means that the head is down.
Oh,
okay.
the head is okay. Head is down.
And then fundal placenta. What does that mean if we're talking about the anatomy of the uterus?
Yes, I'm not sure.
It's okay. It's okay.
We have to go next week.
That's okay. That's okay. Let's see here. Fundal placenta. So all that means is that the fundus of the uterus is at the top. Oh, you guys can't see that. So it's at the top, right? This is super pixelated. Sorry. So anterior is going to be towards the outside of the belly. Posterior is more on the internal side, and then low-lying placenta previa is over the os. So the fundus refers to the anatomical position in the uterus, and that just means that it is at the top of the uterus. Okay. And then its margins are clear of the region of the cervical os. That just means that it's not a previa. The amniotic fluid index is normal, so that just means that there is enough amniotic fluid within the sac. It's not too much, it's not too little. What about on the blood test? Anything there, Mona, that you think is important to know?
Maybe the blood type, A positive.
The blood type is really important. So the A positive means she's Rh positive, so she's not going to be at risk of rejecting a Rh positive baby. And if a baby is Rh negative, it means that they don't have the Rh factor there, so that's not a problem either. It's only when mom is Rh negative that it becomes a problem. What about the platelets and the fibrinogen? Those being normal, why is that important?
Just to make sure that both the baby and the mom are getting enough oxygen to their tissues.
More because it talks about in the last one when we looked through all the labs we were going to do, they talked about consumptive coagulopathy. So if a person is using up all their platelet levels are going to be low. So in something like HELP syndrome, which it's hemolysis, HELP is the acronym. It's hemolysis, elevated liver enzymes, and low platelets. Those are the three things that we would see. And we typically see it in patients that have preeclampsia. It is a emergency. Patients need to be admitted to L&D, and they can become pretty unstable because of the low platelets. And if we're talking about we need to do an emergency C-section on them, then it can potentially be a problem because of the platelets being so low. They have a high risk of bleeding. And so if the platelets are low and the fibrinogen levels are low as well, that tells us that they are using up all their platelets, and they're going to be at a very high risk of bleeding. But hers is normal, so we're good. And then the PTT kind of reinforces that she's not at a higher risk of bleeding. Questions about all of that? Okay. Let's go on. So The patient remains in the ER awaiting further evaluation. 1 hour later, you're called to reassess the patient who has begun complaining of irregular cramping and contractions that are getting slightly stronger. Her fetal monitor now shows the following. So uterine irritability, few contractions with overall minimal variability and periods of absent variability and recurrent late decelerations. Shivani, what does that mean? Just that beginning part with the fetal monitor. What do you think that means?
So it looks, we haven't covered repro yet.
Okay. Let's just kind of take the beginning part. Uterine irritability. What do you think that means?
Her uterus is irritated, and that's probably where the bleeding is coming from.
Potentially, right? So the uterus is irritated. She's getting more contractions now, and so something is causing that irritation. It may be the bleeding. She is having few contractions, but there's minimal variability now. We talked about last time that variability is good. That means that we have a healthy baby. The heart rate is going up and down normal, but now it's minimal. What do you think that means? Or is that good or not?
If there's minimal variability, it means that there's a problem and the fetus is probably struggling in some way.
Yes, and so minimal variability a lot of times problems with variability or abnormal fetal heart monitoring tells us how well the baby's oxygenated. So it may be that baby's not getting enough oxygen at this point. Especially if she's having absent variability and late decelerations. Decelerations so a deceleration happens when a uterus contracts, and if you contract and you have like you have the what is it called? The umbilical cord being compressed.
Mm-hmm.
You basically cut off blood supply to the baby for a little bit, and a little bit some decelerations can be okay, but late decelerations are typically very prolonged, and that tells us that the baby is not getting good oxygen. So all of this tells us that baby's doing good or not good.
Not good. The baby's low oxygen.
Yeah, so baby's not doing too good. On the bedpan, there's approximately 50 cc's of bright red blood, so she is bleeding. Vitals show temp is 37.2, pulse 98, blood pressure 127/81, and respirations 18.
Those all look normal.
Those all look normal, but her pulse is a little higher than it was before, right? Mm-hmm. So, it looks like she may be becoming in a bit more distress. Mm-hmm. So with a known fundal placental location, right? So the placenta is at the top. We can do an exam. We're not increasing her risk of having more bleeding because the placenta was over the cervix. So you do an internal exam. She's 3 centimeters dilated. Cervix is 50% effaced, and fetal station is -3. And there is scanty visible bleeding from the cervix. Do you want to try and interpret that, Shivani?
Okay, I don't think that if you're pregnant, you're supposed to be dilated at all.
Well, yeah, you can. If you're starting to go into labor, you'll start dilating, and even so, in some patients, especially patients that have had babies before, the cervix can become dilated while they're still carrying. So there's some patients that over the last few weeks of their pregnancy, they're at like 1 centimeter or 2 centimeters, and we just keep monitoring it to make sure it's not, dilating even more. And if it dilates more and they go into labor, that's fine. They just deliver a little bit earlier, as long as it's not before 36 weeks, because before 36 weeks, that's when we have to give additional medications, and then there's a bunch of other stuff that we do. But towards the end of the pregnancy, they can become dilated. That's fine.
Okay.
The effacement of a cervix just means how thin it is. So if you're getting ready for delivery, the cervix will become more effaced. So this is a pretty good picture. So this is the cervix is completely normal. It's not effaced. It's not dilated. Cervix is 50% effaced and not dilated. So there's no opening between here and here of the cervix. But you can see that the thickness of the cervix here and here is a little thinner. So this is 100%, this is 0% effaced. This is 50% effaced. This, as the baby kind of descends even further into the canal, you have dilation of the cervix, so the opening starts to open up, and then the effacement kind of as it gets thinner, and if it eventually becomes 100% effaced, that just means that the cervix gets to the thinnest possible point, and then you start to dilate there. And then if you're fully dilated, that's the 10 centimeters, and the cervix will be completely effaced. At that point, the baby's coming out. So that's all that means.
Cool.
So -3 station, that just means the position of the baby. So if you go back here, if the baby's high up in the vaginal canal, and it's based off of like how many centimeters above the vaginal canal it is, the baby would be considered -3, right? So baby's high up, they're -3 station. As they start to descend, they might go to -2, -1, and once they hit the cervix, once you start feeling the head, that's 0 station. And as the baby starts coming out, you have +1, +2, +3 as the baby comes out. So that's all that means. It just means the position of the baby, and it gives us a good indication on whether or not the baby is going to be delivering soon or not soon. And then there's some blood from the cervix. Questions about that at all?
So what would be causing the blood from the cervix? Like, can we like talk about that yet or not yet?
Yeah, so bleeding from the cervix doesn't mean that the cervix itself is bleeding. It just means that you can see it coming out of the cervix. Unless there's some lesion on the cervix, something on the cervix that's potentially causing the bleeding that you can see, it doesn't necessarily tell us that there's something wrong with the cervix itself, just that there's bleeding. Now, that's the question, right? What is causing the bleeding? And do you have, based off of everything that we talked about, what do you think is most likely?
I think that the baby's too high up and it's irritating the lining, and that's causing the bleeding.
Well, the -3 station is normal. That's, you know, if you're starting to, if you're not really quite going into labor yet, that -3 is normal. But I think the next question, hold on, let me see. The next question, okay, what is our diagnosis? Okay, so out of all of these, is there, and anybody can answer this, is there any one of these that are a bit more likely here? So we have abnormal fetal status. Do we have that, yes or no? Does the baby look normal at this point?
No, it has some complications.
Yeah, so the baby's fetal monitoring does not look normal, so I would say yes to abnormal fetal status. What about chorioamnionitis? What is that? Okay, I don't expect anybody to know. It just means that the chorioamnionitis is an infection. So an infection of the amniotic fluid. So if there was something like a, let's say mom got chlamydia or gonorrhea, and that infection ascends into the area of where the fetus is, you can have an infection of where the baby is in the uterus, and that's chorio. Fetal demise. So did baby die?
No.
No, right? So it's not fetal demise. Indeterminate fetal status. I would say yes, because well, no. Jocelyn, why would you say no? Actually, I don't know if you're on Teams. So I would say no, because we already know that the baby's fetal status is abnormal. So I think that's what they're referring to, and then normal would be a no also. I think they're referring to the fetal heart monitoring, like the tracings. if the baby has if the baby's heart monitoring tracing was not quite the way that we see it right now with the late decelerations, lack of variability, but it wasn't quite completely normal, that would be indeterminate. And so there's different categories of the tracing. So a category 1, 2, and 3, and I think that's what this is referring to. And if you guys are interested, we can go through those categorizations a bit later. What about placental abruption? Do we think that this is an abruption? So that's when the placenta is coming off of the uterus and causing that bleeding. So I would probably say
Yes. Yes, because of the irritation on the uterine lining and
yeah.
the
Yeah, so I think at the beginning it was a little bit harder to say because we didn't know. I mean, the patient wasn't having any pain, right? She just had that bleeding, so it made it a little for me at least. It was like, okay, maybe a little less likely. You can't rule it out, but now she's having more pain, more bleeding, and the uterus, if I'm remembering right, is starting to contract a bit more. So it was possible that she had a small abruption, just a little bit of separation, but now that may have increased. So I would say yes. Pre-labor, preterm rupture of membranes. So yes or no? I would say no, because the rupture membrane part, we don't know. We don't have a clear indication if she actually has a rupture of membranes, right? So there was no talk about a lot of like vaginal fluid coming out, and then yeah, Jumbo Shrimp says AFI was normal on ultrasound. So all that means is what AFI is the amniotic fluid index. Basically, we saw an adequate amount of amniotic fluid when we did the ultrasound, so it's a little less likely, but more so we're not seeing that amniotic fluid come out, and they didn't mention it on exam. So so less likely preterm labor because you wouldn't have that bleeding, and then uterine rupture. Typically, you wouldn't be able to find tone on the uterus if it actually ruptured, and I'll pull up a picture real quick. So here. So the uterus is going to be under a lot of tension. If the uterus actually ruptures, you lose the integrity of the uterus. You won't feel that tone anymore. You won't have that contraction, those like contractions as you would feel, as you would see on the regular monitoring, if I remember correctly. So it's less likely. And then a lot of times you will lose that the normal feeling of a pregnant uterus in the belly. And they didn't mention that, but it's a little less likely. So I would kind of leave that out. And we got them all right. Okay. All right. So and when we talked about the fetal status, it's abnormal because she has absent variability and recurrent late decelerations. The indeterminate is they can instead of late, they have variable decelerations. And again, if anybody's interested, we can go over that a bit later. All right, so what do we want to do to treat? Mona, I'm going to go back to you. What do you think you'd want to do to treat? So are we going to discharge her home to bed rest with elective delivery at 37 weeks?
No.
No, right? Baby's not doing good. We're not sending him home. Are we going to admit for fetal monitoring and delivery at 37 weeks?
Maybe for fetal monitoring.
Okay. What if, I mean, does baby look good or no?
No.
No, baby doesn't look good. So we would not want to monitor this. What would you want to do in this case? Does baby need to stay in or does baby need to come out?
Maybe I don't know. Maybe I don't know.
Okay.
Stay in until we figure it out, like how to treat it internally.
Okay. Anybody else want to give their thoughts? So do we want baby in or out?
I feel like out because the baby is not doing well. But
So
it's not that immediate. It's not urgent. So maybe you could just monitor it first and then see.
so baby's not doing well. So baby not doing well. Looks like there's signs of hypoxia, meaning baby's not getting enough oxygen. And it may be because of the amount of bleeding that's going on and the lack of connection between the uterine wall and the placenta. So if the placenta is detaching and is no longer getting adequate blood supply from the uterine vessels, then you are no longer able to adequately oxygenate baby, and so baby needs to come out. And so the question is, are we going to induce labor or are we going to do a C-section? Anybody can answer.
Would we do a C-section?
Yeah, we're going to do a C-section for this because if you're going to try to induce labor, there's too many variables in that. There is a risk of baby decompensating even more, and if the baby already looks good, you're putting the baby at high risk if you're going to induce. If baby was already coming out, like let's say the cervix was dilated to 10, baby's head is there, all right, we're going to push and we're going to get baby out, especially if the baby's already coming out. But if baby's not coming out and it looks like she's at where she's at, I would not want to deliver that, just because it's too high risk. It's way too high risk and baby can die. Do we need RH for this patient?
Yes, because she's negative.
I think she was positive, so we wouldn't need it.
Okay.
Yeah, I think she was A positive, so we wouldn't need it. And then, do we need to transfuse red blood cells? Was the patient really anemic?
No.
No, she wasn't. So we wouldn't need to transfuse. So just the immediate C-section. Okay, so what are the factors of placental abruption? We talked about some of these. So abdominal trauma, yes or no? Yes. So if we have, like we talked about, if we have a car crash, right, and you have trauma because of the car crash, whether that is an airbag, whether that is they put the seatbelt over instead of putting it below the uterus, they put it on top of the belly, and it causes a lot of, if it was a high velocity and it caused a lot of pressure onto the belly, that can happen as well. So abdominal trauma can cause a placental abruption. Chronic hypertension, I think it can. I think that's one of the risk factors. What about cocaine use? Does cocaine cause increased risk of placental abruption? And you guys can guess yes or no.
Yes.
Yeah. I'm pretty. If I remember right, it does. It is a risk factor. Female fetal sex, I don't think so. History of intra-abdominal surgery. I don't know. I think if you've had uterine surgery before, like surgery on the uterus, it can, because of the scarring. I'm not 100% sure. I don't think just in general intra-abdominal surgery is a risk factor. History of previous placental abruption, yes. Null parity, meaning the first pregnancy, I don't think that it's a risk factor. Tobacco use, she does smoke. She does smoke 2 cigarettes a day. Do you think that's a risk factor?
Yes.
Yeah, it is. Tylenol use, I don't think so. In younger maternal age, I don't think it is either. Okay, we got them all right. Although a history of C-section does increase risk. So they're saying, so history of intra-abdominal surgery in general doesn't increase risk, but a history of C-section can. So, okay. In which of the following causes of vaginal bleeding in late pregnancy is a digital vaginal exam contraindicated? And we talked about this. Which one of these would we not be able to do a vaginal exam on?
Placenta previa.
Placenta previa, yeah, and there's one more. I think there's one more.
Would it be vasa previa?
I think it's vasa previa. Yeah. And like we talked about before, it's all about, you know, it potentially disrupting the placenta even more, and you can have more of a bleed there. So placental abruption is premature separation of a normally implanted placenta from the uterus, usually after 20 weeks gestation. It can be in an obstetric emergency. Abruption is thought to be the end result of chronic placental insufficiency or placental vascular disease. So basically, if the placenta is not enough to supply baby or doesn't have a good enough connection to the uterus, it can abrupt like that. So the risk factors include previous placental abruption, tobacco use, which she was smoking, cocaine use. And I believe that is because of the spasm of the vessels going to the placenta, but I'm not 100% sure. Previous trauma, polyhydramnios means just too much amniotic fluid within the gestational sac. Hypertensive disorders, so high blood pressure, preeclampsia. Chorioamnionitis is that infection, and older maternal age as well. So patients will usually have vaginal bleeding, uterine pain, and tenderness. If it's a lot of bleeding, you can get hemorrhagic shock, where you're just pouring blood out and mom's blood supply decreases significantly, and that's when you need the transfusion of red blood cells. DIC is what we talked about. It's a complication of where you're using up all of your platelets, and because you're using up all your platelets, you have a harder time clotting off things, and you end up having a high risk of bleeding. Where was I at? Diagnosis is clinical. Sometimes you can diagnose it by ultrasound. To treat it, you modify activity, so you're going to have moms stay off their feet for most of the day if the symptoms are mild. And prompt delivery for maternal or fetal instability or near-term pregnancy. So if the maternal fetal dyad cannot be stabilized, so like the balance between mom and baby, you can't stabilize it, you need to deliver the baby, usually by C-section if the vaginal delivery is not imminent. So like I said, unless baby's head is already out or is already coming out into the vaginal canal, you're going to do a C-section because there's too many variables involved, and you're going to have a higher risk of fetal demise if you try to kind of induce a labor. Where am I at? So if there's no evidence of hemodynamic instability in the mother or distress in the baby, the appropriate management depends on gestational age. If the diagnosis, so how old baby is, depending on how many weeks. So the diagnosis of abruption is highly suspected and the patient is at term, so 37 weeks or beyond, the patient should be admitted to the labor and delivery floor and labor induced or augmented. That's only if baby is stable. If the patient is preterm, it depends on how severe the abruption is and how well the baby is doing. So if you have a small amount of bleeding which resolves and who have reassuring fetal evaluations, you can do management, expectant management, where you're just kind of waiting until pregnancy reaches term. Any questions? Okay. Tax admin, saw your live and checked it out at the top. Awesome. Thank you for coming on. Send me a message whenever you get a chance. It was one of the comments on YouTube. So send me a message when you get the chance. Any questions at all about this case? Okay. So I was hoping we'd have a little bit of time to kind of go through the other case, but it's we probably are short on time, and I don't want to keep you guys longer than we need to. So the next week we're gonna do a more traditional case. Then we have a week off, and then we're gonna come back for the last 3 weeks. We're gonna do 2 cases that are gonna be kind of tied to each other. One will be 1 week, the other will be the other week. And the most important thing for those cases is to see how to compare and contrast the presentations and what it means for the patient ultimately, and what the diagnosis is. And then the last week we'll kind of do more of an interactive lecture type style, and I'm thinking it's going to be based off of vaccines and infectious diseases. So questions about anything at all for those that came late? The courses are now able to be re-enrolled in. I'm going to put 2 more for the VMR sessions for 5 and 6 up, and so you can get that done. And again, you have until the end of the end of the course to finish these all. And if you need more time, just because of all the hiccups along the way, we'll kind of figure it out. Questions at all? If not, yeah.
Question, going all the way back to the GP code, for the number, I think it was, for A, for abortions, does that include elected and spontaneous abortions?
Yeah, it includes both.
Okay, thank you.
Yeah, and again, this is not OB is not my specialty, so it's been a while since I've delivered a baby. So hopefully, if there is something that I messed up, and if anybody wants to point it out and send me a message, it helps with my learning too. So feel free to do so, and then I'll correct it for everybody else too.
Did you deliver babies in medical school?
In medical school, I did. I've delivered about, I think, 5 or 6 babies total in med school. In residency, I think I was up to 45 or 50, somewhere in there. And I did assist in some C-sections as well. Yeah, so it was, it's a lot of fun. I love OB. It's a great field. And I was thinking about doing if you're family medicine, you can do a fellowship in OB. And so it's a 1-year fellowship where you do more deliveries and you get trained in C-sections. So that's always a possibility. If you like seeing everything, you can do something like that and retain those skills. And then for Jocelyn, Jocelyn's asking if we can put the link for Scholarly. I'll actually I'll put it in right now, but then I'll also send you guys another email as well. Okay.
Quick question.
What's
What are the different fellowships you can do from family medicine?
So there's quite a few. There is sports medicine, addiction medicine, there is geriatrics, there's lifestyle medicine and integrative medicine. There is OB. You can do, what else is there? There are some non-accredited like dermatology fellowships. I don't know, if that changes your scope of practice at all. Not 100% sure. Yeah, if you look up family medicine specialties, there's a huge list of them. And if you're interested, send me a message. I'll send you that information.
Okay, thank you.
Other questions? And if you guys don't have any questions, feel free to jump off. I don't want to keep anybody here. But I'll stay on until all the questions are answered. Okay, it looks like we're good. And yeah, any feedback that you have, just let me know. And I'll see you guys next week. Take care.
Okay,
Thank you. Have a good day.
Have a good
Thank you.
Bye. Shivani, do you think you and Mona have a sec to kind of go through things?
Yeah, I think she left. Let me ask her to come back.
Okay. I'll send you a new message so it's not on here. Okay.
Okay. So
All right.
yeah, I'll wait for your email and I'll text her as well.
Sounds good. Bye.
Thanks.